Good afternoon. Thanks for joining us, both here in person at St. Paul's Hospital as well as over Zoom. And today our speaker is Dr. Vivian Tsang, who's a resident at UBC Faculty of Medicine, Department of Psychiatry. And today she'll be presenting a very interesting project that's done in collaboration with an organization called Roots to Thrive and Drs. Shannon Dames and Pamela Crisco at Vancouver Island University. Some of who are here on the Zoom call. And the title of the talk is Safety and Tolerability of Intramuscular and Sublingual Ketamine for Psychiatric Treatment. And I'll pass it on to Vivian. Join me in welcoming her.
Thanks, Lily, and it's a pleasure to be here. So thanks for having me for this talk. This is going to be a presentation on the work with ketamine-assisted therapy program as part of the Roots to Thrive ketamine-assisted therapy program. A caveat to this presentation is that I am very much a learner to this space, both in psychiatry and in this research work. And I come to this presentation with my hats as a third-year psychiatry resident in the research track program with an interest in addiction psychiatry and emerging pharmacotherapies, as well as part of the research team at Roots to Thrive. So it's very much a privilege to be able to be giving this talk. But I want to say in advance that I'm by no means an expert, and I'm very glad that Pam and Shannon are on the call today to also field any questions that might come our way. So looking at safety and tolerability is really paramount, especially because we are a community clinic and we're not tied to a hospital or a university per se. And we very much operate with real world patients. So although our clinic is a nonprofit organization, the ketamine program is a program that in which patients pay kind of an at-cost price for participation. And because of this, we're not exceedingly selective about our patient selection, just like different than a clinical trial would be. And we did accept the majority of people who apply to be in the program, especially in the early cohorts. So overall, this research is important because we're able to improve access to care, improve the availability of ketamine and psychedelic-like programs, in which our patients are increasingly asking for, and also to publish on real-world data and how this therapy actually works in practice. So this was a retrospective chart review of cohorts 1 to 4, which went through the program between September 2020 and December 2021. However, I thought before we kind of dig into the meat of the actual study that it would be interesting to also tell you a bit about the program's contextual makeup in this presentation as well, before we get to the results of the data. So as many of you already know, ketamine has been used as an anesthetic since the 1960s, has a very well-established safety and efficacy profile, and currently ketamine is the only really widely available psychedelic-like medicine that is legal in Canada. However, even in this use of it as a psychedelic-like agent, ketamine is used off-label, which lends to multiple complications and difficulties, as I'll mention later on in the presentation. The ketamine experience is similar to a psychedelic one in that it promotes openness to the expansiveness of the mind and enhances the patient's ability to meaningfully engage in therapy. To leverage this potential for therapeutic engagement, they created a group protocol termed the Roots to Thrive Ketamine-Assisted Therapy Program, which I'll be referring to as RTT-CAT through the presentation. So RTT-CAT is a 12-week program with weekly therapy sessions and 3 medicine sessions integrated throughout. So initially it was designed actually to address caregiver burnout, but the program has since been adapted to treat patients with a variety of different mental health challenges. So everything from depression, PTSD, chronic anxiety, and we'll go over the specific recruitment criteria later. So although ketamine is not a psychedelic, it also, as I mentioned, induces a transient altered state of consciousness with similar hallucinogenic experiences. Although there are unwanted side effects, for example, dissociation and psychomimetic properties, it is not the same as a true psychedelic. And as I mentioned, it is the only legal and readily accessible psychedelic-like option here in Canada. Ketamine has actually received quite a lot of attention already, especially in its intravenous routes of administration. So there's lots of studies out there with IV ketamine. In a more recent open label randomized trial by Anand et al. With 400 patients randomized between ECT and ketamine for treatment-resistant depression, 55% of patients in the ketamine group and then 41% of patients in the ECT group had positive responses, which for them was measured on a 10-point decrease on the KIDS SR scale. So lots of evidence has already been done, but less so in the intramuscular and sublingual and other routes of administration. So a bit about the history of psychedelics in Canada. I think it's really important to situate this talk in kind of what has been happening and the difficulties in accessing psychedelics, hence why we need to turn to ketamine in the first place. There was an initial clampdown on psychedelic research really in the 1980s. Health Canada has been very strict on reintroducing psychedelics into the medical landscape. As of August 2020, true psychedelics such as psilocybin, for example, were government exempt, which is a program that would allow patients to 1 year of access to psychedelic therapies. And indeed, this was an exemption from the law and was done on a case-by-case basis. At the time, it was mostly patients with like a life-limiting illness that would qualify. And Exemption 56 forms were filled by patients themselves, obviously with help from their medical teams and legal counsel as needed. Now, as more trials and evidence became available, the federal government and Health Canada turned to a special access program model, which then allowed individual patients to access psychedelic assisted therapies. And this SAP program was not unlike other special authority forms that physicians filled out for, secondary lines of medications for patients. But the difference is that with these SAP forms, physicians filled them out for their patients, and it's quite lengthy in terms of the number of details you'd have to put in and how you make your case for your patients. Now, at this time, Exemption 56 still existed, but the promise by Health Canada is that the move to SAP would expedite a vetting process for patients, especially those, for example, at the end of life, so that they could have faster access. However, unfortunately, thus far, the access hasn't really been much faster than in the original program, which is a problem. Approvals are also quite nuanced. So for example, 1 or 2 similar patients with a similar application can be submitted. One would be denied access and the other gets approved. It really is kind of a case-by-case situation. And we've tried to inquire about strategies or things that would make it easier to approve patients, but very much that's kind of still the case right now. Fast forward to present day, Health Canada is now also pushing for psychedelic access to be obtained mostly through clinical trials, with SAPs and Exemption 56 as kind of now like secondary options. But as you can imagine, it's very, very difficult to access or find and qualify for a clinical trial. So in terms of coming back to our program, the RTTCAT program, our referral process, potential participants are referred by a healthcare provider. So typically their family doctor, a nurse practitioner, or a psychiatrist, and all participants undergo a series of assessments as part of their medical screening process, including full medical consults. And patients on multiple psychiatric medications, we usually always also ask for some kind of documentation or clearance from their psychiatrist, especially when the situation is a bit more complex. We do also have an in-house psychiatrist who works within the program as well, so that's very helpful. So in terms of the inclusion criteria for the program, patients who are accepted have to be 19 years and older. We have been looking at models for younger patients, but in the kind of general RTTCAT program, they do have to be an adult. They have to have a diagnosis of some sort, a DSM diagnosis. So these are usually PTSD, depression, substance use disorder, anxiety, disordered eating, or issues with sleep, with typically poor responses to standard treatment. They have to have a willingness and capacity to be engaged, open-hearted, and be a consistent participant in the weekly small groups, the weekly therapy groups that they're in. And then there's some practical things. So if you have a child, we ask that you arrange childcare. If the individual is self-medicating with substances, the impact of that cannot interfere with their capacity to be present in therapy. They have to have reliable internet because many of the sessions, so the preparation and integration sessions, which I'll talk about a little bit later on, are via Zoom because we have participants coming in from different parts of not just Canada, but elsewhere as well now. And they also have to be able to attend in-person ketamine sessions on Vancouver Island, so at our facility. So we do have a lengthy number of exclusion criteria, including diagnoses that would make it unsafe for a psychedelic-like experience. So for example, and this is of course taken on a case-by-case basis in discussion with their physician and with our physicians as well. But some examples might include like a recent change in their psychiatric medications, any history of psychotic symptoms, current or recent history of dementia or delirium, as well as medical conditions that would put someone at high risk of side effects, such as untreated or high-risk coronary artery disease or cardiopulmonary diseases, a history of aneurysms or hemorrhage, hepatic diseases, and pregnancy. And of course, everyone has a discussion with our physicians on intake as well as their own physicians. So I'm listing this lengthy list, but of course we tailor that based on the individual and what situation they're presenting to us with. So once referrals are reviewed for completion and provided that the patient meets criteria, they then complete a variety of symptom rating scales, also identifying their goals for treatment. And this comprehensive screening process prioritizes the safety, suitability, and overall well-being of participants. The baseline data is really also critical for evaluating outcomes and informs ongoing program development as well. So both for a QI and research purposes, it's important to gather this data. Now, as we continue seeing progress in this area of research, we'll likely have more patients asking about ketamine and psychedelic-assisted therapies, or maybe you might be assisting patients with ongoing psychiatric treatment or therapy, patients who have gone through these programs. So next up, I wanted to walk through a little bit of the flow of a ketamine-assisted therapy protocol, kind of like the nitty-gritty of what happens during each of these sessions and the flow of the overall process. So in general, ketamine-assisted therapy, or CAT, has 3 phases. So the first is preparation, second is a dosing session where they actually receive the ketamine, and then integration. So I'm going to briefly introduce the terminology as well, so we can have the same language moving forward in the presentation. So preparations and integration are both facilitated therapy sessions, with the only difference in that, of course, they have different content, but one happens before and the other one after a ketamine session. In our program, they're both done with about 8 participants or patients in a small group using our communities of practice model. The ketamine sits are, as I mentioned, the medicine sessions themselves, where patients are administered either the intramuscular or sublingual ketamine in this study, and the entire sit or session is done in a group setting with 2 therapists per patient. Now, each of these components also have a specific purpose for why they even exist in a protocol in the first place. So breaking down a little bit more, the preparation stage includes all of the therapeutic components before the ketamine medicine. So it includes, for example, assessing for medical and therapeutic readiness, developing rapport with the patient, building safety and trust, crafting intentions and agreements, which I'll go over later, and then making preparations for the actual dosing sessions. The ketamine sessions, or SITs, includes everything from setting up the space, dosing the medicine, administering the medicine, and then managing the patient to kind of the understanding what happens in each phases, because, for example, giving the injection or giving the tablet patient to take sublingually. And then includes the therapeutic components after the ketamine medicine, which body work, reinforcing strength teams, and then of course continued therapy afterward. So we developed a therapy program, community of practice, which is a people value of unconditional positive, with the goal of really bringing active awareness patterns that create distress. And this practice is based on 4 core practices, which are then reinforced throughout the program. So the first one is conscious awareness, and that is of oneself, of the world, of resources available. Second is regulation of the nervous system. compassion for self and others, and then alignment with one's purpose. And strategies for developing these practices may include things like mindfulness, meditation, specific breath techniques, somatic experiencing and awareness, as well as self-compassion practices. Now, as I spoke to before, intentions and agreements are really important, and often these are terms that aren't used in the rest of medicine. So I thought it was also important to break this down and explain a little bit of what they mean. Intention setting and the creation of agreements is actually really critical in the preparation stage before patients partake in the ketamine sessions themselves. So to start off, intentions refer to kind of generally the goals of therapy. You can think about it like that. This is usually discussed between the patient and the therapist during the preparation sessions, but some patients actually come to CAT with quite a clear idea of their goals. This is especially prevalent for populations such as end-of-life patients, where there are usually common intentions that follow relevant themes, for example, grief and loss, legacy, and things like that. Now, agreements refer to the rules and guidelines during the dosing session. So all of the agreements are discussed in preparation sessions and are again reiterated for consent purposes before patients receive ketamine. And patients can change those agreements depending on kind of how their sessions go in subsequent sessions as well. So these agreements are, for example, include things that keep the participant safe, that keep the therapist safe, and keep the session kind of running smoothly. And so they might include things like staying inside as much as possible, making sure that they agree that they're not going to harm themselves or any of the therapists or the property, that they agree not to leave the premises, and having emergency contacts and other details decided on before the patient becomes intoxicated. This is also a really important step where touch is discussed as well. So how much touch? Is that just a hand on their hand? Is that a hand on their feet? What's appropriate? And then kind of sticking to that during the ketamine session. Of course, that's super important. Now, here is like a rough schedule. It's not always as perfect as this little schedule, but how it reads is kind of top to bottom and then left to right, with the 12 weeks of therapy indicated in kind of like the middle chunk. Attending the preparation sessions is actually mandatory. So we ask if they attend 3 out of 4 for ensuring intentions and agreements are done and to cultivate relational safety prior to ketamine sessions. It's also for, again, establishing clear intentions and agreements that align with the program's guiding principles, and it serves as a foundational step in developing a strong and sustainable communities of practice. Participants were also coached on navigating. I'm just going to wait for that.
Code Y, Providence, 9CD. Code Y, Providence, 9CD.
The realities of presenting in the hospital, right? As I was saying, participants were also coached on navigating challenging experiences that they might encounter when under the influence of ketamine. And they're also supported to integrate any of these challenging situations in their follow-up integration sessions with the group, and additional support offered as needed by team therapists, as well as our psychologists and psychiatrists. Now, before the ketamine sessions, when patients actually arrive on site, we establish a medical baseline. So that includes taking things like vital signs, doing like a brief mental status exam, and then they go through their dosing and consent conversation again with the MDs on site, and any changes that they want to make the day of can be accommodated. The session usually begins with a basic breathing exercise or somatic activity to engage the group in their communities of practice before the ketamine is administered. Now, this is the setting of what something like this might look like. As you can see, it's a very different type of environment. Now, this isn't our clinic in particular, but the clinic space is set up to be inviting, calm, and peaceful overall. As you can see there, participants wear eye shades. They're also like listening to headphones with music. As an aside, we actually have a study that we're planning looking at the impacts of different types of music on the outcomes of therapy, which is really interesting. But usually the playlists recommended are, for example, classical music, which is heard in the infamous Hopkins playlist, grounding folk music, shamanic drumming were appropriate, and ambient kind of waitlist types of music. And so at Roots to Thrive, we have different playlists that we've curated over time that are usually used. But this is also something that participants can suggest if they have a preference or a type of music that they're curious in trying. So in cohorts 1, 2, and 3 in our study, the first ketamine session was administered via sublingual formulation. So that's actually in a lozenge from kind of ranging from between 100 to 300 milligrams of ketamine. And the lozenges at the time of administration were kind of like taken orally in the mouth. They're broken up, swished around for about 20 minutes, and then spat out. So as you can imagine, quite a kind of complicated process. And then the 3 cohorts engaged in their second and third ketamine sessions via intramuscular gluteal, so either a gluteal or deltoid injection of ketamine. And this was done in a weight-based range, so kind of between 0.5 to 1.5 milligrams per kilograms. And then the doses used in our study range from 45 to 145 milligrams. Now in cohort 4, all 3 ketamine sessions were delivered intramuscularly. And this is really the main driver of this is due to participant feedback from cohorts 1, 2, and 3. As you know, you can imagine it's very messy to swish and spit and also took a long time. The IM administration also allows for additional enhanced dosing precision, increased bioavailability, as you can imagine, and then feasibility of administering, by nursing staff as well on the day of. Now, common and expected side effects of ketamine include things like lightheadedness, transient elevated blood pressures and heart rate, nausea, and then temporary anxiety. In terms of our protocol, we measured blood pressures before, during, and after ketamine sessions, and then offered both behavioral as well as pharmacotherapies for transient hypertension, and then pharmacotherapies for other symptoms such as nausea, headache, and anxiety. And we actually have quite a strict protocol for the hypertension piece because that's as you can imagine, a medical risk. So should a patient arrive with blood pressures above the allocated cutoff, for us it's 150/90, they'll be brought to a private room. First, we'll ask them to sit quietly for 5 minutes, doing some relaxation exercises, and then we'll do a repeat blood pressure. Now, if that blood pressure is still above cutoff, then usually 0.1 to 0.2 milligrams of oral clonidine was provided, and then the patient was again retested kind of 20 to 30 minutes later. But if the blood pressure is still above the cutoff, the participant is actually at that point discharged home and ketamine was not given that day, and we have to prioritize safety of the participant and kind of having a discussion with them to optimize kind of future sessions. And these were actually the PRN doses or dose ranges of medications that were offered and worked well for the majority of patients. So to address anxiety, we had lorazepam or Ativan on hand. For hypertension, the clonidine as mentioned, or captopril. For nausea, we offered ginger tablets or ondansetron, and then headaches, Tylenol, and ibuprofen. So after completing post-CAT initial integration, participants are picked up or actually have travel accommodations arranged for their safety. An emergency contact list is provided to allow all participants to reach study team members at any time of the day to discuss concerns relating to the session. And this is really to ensure their safety and well-being immediately after the CAT sessions. Participants are also given the option of attending kind of 2 or 3 more integration sessions prior to the next scheduled online integration session. And of course, this might look a little bit different depending on the cohort and depending on kind of how many facilitators or guides are available. Now, ideally, kind of within 24 to 72 hours, participants can attend at least one of these post-session integration sessions. It's really an ideal time to share and to be witnessed as participants integrate new insights emerging from that experience, the CAT experience. Integration is supported as an essential and kind of ongoing process. Our understanding is that by cultivating secure attachments to others in their existing communities of practice, the participants have a greater ability to kind of trust in the process. And then at the same time, they're actually supported by others who understand the efforts and rewards along the way. So along the kind of entire CAT journey. There's also very little evidence that simply taking a psychedelic substance or a psychedelic-like substance by itself will actually translate into lasting changes in life. So for example, in a lot of the phase 2 clinical trials at Imperial College, patients who either like dropped out of the study or didn't kind of complete the study with full integration, 60% of them actually reverted back to kind of their old patterns of thought and behavior by the 6-month mark. So I think that evidence is pretty important to regard, and now more and more studies are coming out about the importance of the integration process as part of the CAT process. So there are many ways to integrate the dosing session experience. So for example, encouraging patients to continue working with their therapist and in complementary therapies. So for example, mindfulness-based therapies or EMDR, whatever is fitting for their diagnosis. For some patients, it'll be helpful to integrate the experience physically as well. So things like yoga or Tai Chi, art and dance, and then other creative pursuits, typically like aligning with what they already do. So what their all like existing passions and interests are as well. Reinforcing and strengthening individually and in community will often aid in the connection of themes, and then also promote emotional and behavioral changes as well. So in our program, we facilitate opportunities and encourage participants to continue to actually meet with their communities of practice groups, so that kind of group of 8, well after the conclusion of the formal program. We also have an alumni kind of group and events, and also offer the option for alumni to revisit a ketamine session in the future, if possible. So it's pretty important after sessions to also counsel patients about the following things. So, of course, taking time after a major therapy, a major program like CAT, to reflect on changes and insights derived from therapy. For example, keeping a journal, continuing with integration, all the things we talked about. Also cautioning patients not to take every vision they experience literally, not to make dramatic changes to life immediately after having a ketamine experience, and to be also cautious of what they share with others, especially outside of the therapeutic space, knowing that CAT is a pretty special intervention, and noting that they're vulnerable after finishing the therapy. So now we've covered a lot of the context of what this program is like, how many weeks it takes, the flow. So I'm going to share with you some of the results from this specific study using this protocol. So all in all, RTT-CAT was very well tolerated, with actually no participants at all dropping out of the program. So in total, we had 128 participants, skewing more females than males, and they contributed to a total of 448 total sessions, so ketamine sessions. And the numbers, you might be thinking like that doesn't math, but the numbers work out this way because there are actually 29 instances of individuals participating in 2 cohorts. So of course, we regard them as like the same person, just having more sessions contributing to the data. So in total, there were 351 intramuscular sessions and 96 sublingual ketamine sessions. And the average ketamine dose used in the IM sessions was 102.5 milligrams. The average ketamine dose used in the sublingual sessions was 276 milligrams. The difference there is really due to the bioavailability as well. As the oral sublingual lozenge is much less bioavailable than an intramuscular administration would be. Now, adverse events were addressed by nursing staff, and they were also recorded and documented during the ketamine session itself, and then followed up directly after treatment, as well as 30 minutes post-ketamine. All of the adverse events, including anything that was expected and unexpected, were recorded as entries on session forms, so the actual kind of charts that they used at the ketamine sits themselves, and those were completed on the day of the ketamine administration. Now, in terms of adverse effects, doing our best to account for some missing data, about 12% of overall sessions reported some degree of nausea, but only 2.5% had an episode of actual vomiting. 3.4% reported headache, and then 1.5% of sessions experienced dizziness. Also, among sessions that used medication prophylaxis, only a minority of the sessions had documented adverse events. However, one thing to note is that the headache prophylaxis with things like Tylenol and ibuprofen was less effective than, for example, ondansetron used for nausea. Now, comparing routes of administration, overall, more participants in the intramuscular sessions experienced side effects compared to those with sublingual session. This is particularly pronounced because often these participants often served as their own controls in a way, right? Because they would have gone through the sublingual sessions and then gotten IM subsequent to that. And then usually had no side effects in the first sublingual sessions and then subsequently experiencing side effects in latter sessions or in both. In terms of the stats, about 13.3% of IM sessions experienced nausea compared to 8.3% of sublingual sessions. And then intramuscular sessions also had a higher incidence of headache, so 4% versus 1%, and then dizziness, 2% versus none. And overall, very few individuals experience these side effects at all. And then the differences in terms of between intramuscular and sublingual sessions were also not statistically significant. So that's important to report. And it was also interesting that of the patients experiencing side effects, I think based on a few slides earlier, patients overall still preferred the IM administration, which is important to note. Now, transient elevated blood pressures above 120/80 were a very common pre-ketamine occurrence, as well as a post-ketamine side effect. So about 36.9% of sessions had participants with elevated BPs prior to ketamine, so they kind of came in hypertensive, and then 49% had elevated blood pressures post-ketamine, which again speaks to the side effect of ketamine, actually causing transient elevated BPs. Intramuscular and sublingual sessions did not largely differ in the average pre or post ketamine blood pressures. And all of these transient BPs did eventually resolve on their own. So either kind of patients waited it out or they got PRN medications. But I think of all our patients, only like 5 patients got prophylactic clonidine. There were no hypertensive emergencies to note, and no other more serious adverse effects stemming from the transient hypertension. So overall, very safe. Now, to speak about differences in side effects between genders, it was found that more males did experience pre-ketamine elevated BPs compared to female participants. Males also experienced higher rates of post-ketamine elevated BPs compared to females, but females had significantly higher incidences of nausea. Now, stratified by age, post-ketamine transient elevated BPs were more prevalent among older participant cohorts, which kind of makes sense, right? Like peaks in participants aged 61 to 70 years old, which accounted for about 71% of sessions. And it likely in our data only decreased in the 71 to 80-year-old cohort because we only had 5 sessions in that cohort. So likely due to limitations in sample size. There were 96 patients with previous psychiatric diagnoses. And in summary, these patients accounted for the majority of reported adverse events across all sessions. So like 75% of sessions with nausea, 78% of sessions with vomiting, 83% of sessions with headache, and 76% of sessions with anxiety. So that's an important takeaway because we've since now gotten better at offering prophylactic medications for these patients prior to ketamine sessions as well. Now, the incidence of adverse events such as nausea, vomiting, headache, and dizziness were similar in our studies, compared to past studies of ketamine-assisted therapies that also use sublingual and intramuscular routes of administration. In particular, the rates of nausea and vomiting in this study were higher than in-home sublingual administration, but lower than in-office sublingual or intramuscular routes of administration. So you can kind of see where it sits in terms of side effects. The use of medication prophylaxis has also proven to be effective in preventing these adverse events. And it's a helpful finding which contributes to best practices in either individual or future group CAT as well. All patients were actually normotensive at baseline, either with or without pharmacotherapy, prior to enrolling in RTT-CAT. So really the changes in blood pressure prior to the CAT sessions could be due to anticipatory anxiety, also known as white coat hypertension. Ketamine is also known to raise blood pressures as an expected side effect. So the post-ketamine hypertension is probably related to a mix of still probably white coat hypertension, but also ketamine-related hypertension and a combination of the two. Our studies documented increase of about 12% of elevated BPs from pre to post CAT is below that which is documented in literature as well. So it really shows that kind of where we sit in the overall existing scientific data out there. Now, this study reports on the realities of operating a community-based CAT program, which again, as opposed to a controlled clinical trial or a hospital environment, there's lots of differences in terms of, everything from patient recruitment to how things are done during the therapy to availability of data even. Overall, however, RTT-CAT was very well tolerated as shown from our data, and common side effects were pretty readily mitigated by either a mix of prophylactic and symptom management, symptom treatment with pharmacological interventions. And documenting and publishing on community-based research really allows for the creation of similar programs and sets also realistic expectations for existing group CAT programs as well. And what this might look like when it actually gets rolled out for patients on a larger scale than a clinical trial, for example. So that's it for this presentation. Thank you all for listening. And since this research project was really for the first 4 cohorts, we've now done another like 6 to 8 cohorts of CAT. So we have much more data, and hopefully once our ethics gets approved, we can publish on that hopefully soon. So that's it. Happy to take questions and have a discussion. And once again, I am very happy that my colleagues are here because I think a lot of the questions can probably be fielded by a combination of all of us. So that's it. Thank you.
Meantime, hopefully they can hear me. Thanks, Vivian. That was a great presentation, very informative and fascinating. Can you tell us a little more about the Indigenous involvement in this type of work? I know that both Vancouver Island University and the Roots to Thrive program are kind of leaders in that field of incorporating, other ways of knowing and traditional practices.
Yeah, for sure. Thanks for that question. And this is something that we've more recently formalized in creating the Natsamat Center for Psychedelic Studies, which is hopefully going to become this Western Canadian hub that will allow for multi-eyed seeing and different approaches of coming to research. Maybe for this question, what I'll do is maybe if I can pass it to Shannon if she's still on the line, and maybe Shannon, if you can comment a bit more on kind of the current integration of the Indigenous involvement in the program itself, that would be probably helpful.
Yes, I can. Hi, Vivian. Thank you for that. Am I coming through volume and video wise? Yes. Okay, great. I can't see what I look like, so I'm hoping I don't have anything on my face, but I'm just going to go with it here. So in just maybe starting on, I think, thank you, Vivian, for laying such a solid foundation. This is, I'm hemming and hawing a bit here because there's a lot of gray areas in how we move and in the development of this field and what cultural bridging looks like. And some really sensitive areas because it's a significant topic, and there's not a lot of black and white answers to how we do this in these very fluid times. That's kind of my disclaimer to saying I'm going to give a little bit of a description here, and there's a lot of unknowns that I'm still sorting through as well. When we began this program in 2018, the Roots to Thrive kind of model, it was in partnership with Island Health and Vancouver Island University. And it included an Indigenous elder and also somebody who would not call themselves an elder, but that was both kind of heritage-wise or lineage-wise, Métis, 50%, and coming from European ancestry on the other side. So we had a lot of the mission in this was looking at how do we really honor that there are Western individualist approaches that really are driving a lot of our, I would say, our programming and also our mental health. And how do we also honor that there are Indigenous ways of knowing, and not just Indigenous ways of knowing, but other traditional ways of knowing that many of us have had in our lineages, since time immemorial, as they say, and have lost those over the last hundreds of years and have become a lot more individualist in our ways of knowing. So there's been this weaving from the beginning of really honoring that, in resilience research, and that's kind of where I specialize, humans are born to be in community, in relationships, and individualism in many ways is toxic to how we are actually most able to flourish and function as humans. So it's this weaving of how do we bring these, I'll say, resilience ways of knowing, which are actually more aligned with Indigenous ways of knowing, and promoting thriving in human beings, into a curriculum that is largely regulated and, for many intents and purposes, needs to be evidence informed. So all that to say, we've had multiple projects, including we have 10 to 20% in any given cohort is Indigenous. And we always are running a quality improvement process underneath our programming to gain insights into how we can be more respectfully responsive culturally without crossing into appropriation. And that's always the tricky line, is how do we really honor these ways of knowing without appropriating? How do we work in ceremony? Because ceremony is actually like a human need, without crossing into religious connotations or cultural connotations. And all of this is really bridging cultures in many forms. Did I kind of hit that?
That was great. Thank you, Shannon.
You're welcome.
There's a question on Zoom here. Any thought on post-alcohol detox use of ketamine therapy before discharge?
Yeah, thanks for that question. I guess this is like a little disclaimer, but we did apply to a recent SUOP grant, which we should know the results of soon, if not already. But we did hope to pursue the treatment for especially folks with alcohol use disorder, not in particular kind of a post-discharge setting, but more kind of all-encompassing AUD as the main indication, and then also focusing on an Indigenous population for the recruitment as well. I'm not sure who wrote that question. Maybe it's in the chat or something, but would love to hear more from them about thoughts about the post-discharge especially, or whether kind of they're curious about that specific area within AUD.
Another question asking that it's 2 therapists per patient. Is that correct? The requirement.
Yeah, that's my understanding of the protocol that we have. Obviously, the therapists in the room are, they're available for their patient. But I think that maybe if we can ask Pam or Shannon to comment more on that, that is my understanding of the current protocol.
Can I hop in here? I saw Pam put something in the chat box there as well. This is another area. So per our protocol, it's 3 participants per 1 provider at a very minimum. And that, if you reduce that down to just having 3 patients, that is assuming you're in a group of patients. So, and we would always have a therapist and clinician pairing. And we have more than 6 participants. We generally have 8, and that means we have at least 3 professionals in the room. One of those represents a clinician at least, and one represents therapy at least. And then we generally have a somatic therapist in there as well. So there's kind of 2 therapists, one that's really working with the body and the energy field, one that it's more of a kind of talk therapy specialty, one clinician that's making sure the biochemistry of the body is safe. And then if we have one more in there, and we almost always do, it would be another clinician that is kind of just really ensuring, like if one clinician needs to room, that we always have one clinician in the room.
Thank you so much. And Tony, would you like to ask your question?
Thank you. Tony Phillips here. Thank you for a very comprehensive introduction to this fascinating topic. Could you provide a thumbnail sketch about what the Roots to Thrive program is focused on? And then do you have a hypothesis about how ketamine might facilitate that process even further?
Yeah, sure. I'll comment a little bit about the different arms of the program as it currently stands. And then maybe Shannon, you can take the second half of the question, although I'm also happy to give it a stab. So right now, Roots to Thrive, well, actually backtracking a little bit, even in our first cohorts, we are really emphasizing the kind of relational and therapeutic components of the program as a whole. So actually starting off, we did have groups, communities of practice groups that did not have the ketamine. And so we, not this study, but a different study commented on the differences and similarities between outcomes of the folks that participated in the same therapy model without ketamine compared to folks that had the ketamine addition. And that paper is available for everyone to read, but the kind of Cole's Notes spoiler of the outcomes is that there were no clinically or statistically significant differences between the two groups. So that really speaks to the effect and impact of the therapy model itself. In terms of the Roots to Thrive kind of arms as it stands right now, we have the RTT-CAT arm, which is described here as the ketamine assisted therapy program. Also, we have a PAT arm, which is the psilocybin assisted therapy program. And participants come to that program mostly through SAPs, as well as exemption 56s. Of course, in terms of numbers, we have not run nearly as many PAT sits and programs compared to the CAT, but that very much is an existing and ongoing arm of the program. And then very recently, or more recently, we started an MDMA harm reduction arm. And that one is only kind of between 5 and 10 patients in, but is in kind of a hoping to be an emerging and bigger arm of the program moving forward. Yeah, I'll pass it off to Shannon to maybe comment a bit more about hypotheses and elaborate a bit more about the model.
Thank you.
Yeah, I've just put in the chat box there as well. Thank you. There's two major informing. One is, really doing this cultural bridging effort. In Western medicine, we focus on Western research. So a lot of the RTT program, and I'm a Western researcher myself, and I was kind of spearheaded this back in the beginning and was studying resilience in my doctorate program. So a lot of this was built around how do we, clear the noise of a lot of the self-help material out there and really understand what works to help human beings become resilient. And what does the research say works? And that was a lot of the programming was initially built off of that. And then we've been weaving in with these principles of Indigenous ways of knowing. And again, kind of expanding beyond what's written in the Western research, which actually aligns a lot with a lot of Indigenous oral research that's been passed down through many generations, and really working with that kind of cross point of where we're seeing Western and Indigenous ways really come together. And we call that kind of coming together in a bit of a third space, so there's kind of sharing these common truths among all humans. Yeah, I'll leave it there.
Thank you. Just to follow up, if I may. So the people that come into your program, do they come in with a variety of issues that they're trying to address personally? So it's a variety of things. It could be an addiction problem. It could be a mood disorders issue. It's heterogeneous in terms of what the individual may be trying to gain help for. Yeah,
we've really been trying to focus less on the symptoms that are coming on the surface, right, which are, can be very diverse when really underneath the seed of a lot of our symptoms and diagnoses is a common challenge of disconnection and insecurity. So the programming is aiming at disconnection and insecurity, recognizing that even the loosening of addictions and many of the kind of, I have all sorts of terminology that I call different diagnoses on the surface, but they are very common with a lot of the syndromes and diagnoses that we see in Western medicine.
Right. So,
Thanks, Shannon. And just to maybe comment on that a little bit further, in terms of the data, not all, but many of the patients that we have in terms of the reported diagnoses, they don't report just a primary diagnosis, but so often a secondary and then sometimes a tertiary diagnosis as well. So definitely a mixed group. So just wanted to add that in.
Right. And when you use the term resilience, are the people being resilient or more resilient after they undergo this routes to therapy, to thrive, sorry?
Mm-hmm.
What's the base? I'm just trying to get an idea of how you measure change. So you have a reference point at some junction, perhaps when the person first enters the program, you do an assessment, and then they undergo the sessions and perhaps become more socially aware or whatever. And then how do you identify resilience and whether or not it's present and whether it's improved?
It's such a good question. And it's really challenging to measure the big picture of resilience. We work with two factors in the program, one being congruence, which is one's ability to feel secure enough and worthy enough to show up authentically in the world, which means, you're not doing a lot of displaying. When your body says yes, you say yes out loud rather than the opposite. That's a measure of congruence. It's that congruence also relates to perfectionism, self-compassion, how much shame people carry on a day-to-day basis. Mm-hmm. And the other measure is sense of coherence, and these are both not coined by myself. First one was Carl Rogers, second one, Aaron Antonovsky. And it's around meaning making, understanding, predictability in your world, and the confidence to face challenges without kind of receiving them as a threat, more stimulating than threat. These are really hard to measure with what, in Western medicine, with our kind of black and white measuring tools. So we measure them based on how people are showing up on the depression scales, on the anxiety scales, on the PTSD scales, and on the life work functionality scales. It's not perfect by any means, but we're essentially working on the roots of the problem, and then we are studying the symptoms of what happens when you don't have those factors. So it's not a perfect connection by any means.
Thank you.
And just to add a little bit there as well, there's separate projects looking at qualitative measurements, and some of the questions that we ask do touch on some of these themes as well. In the cohorts 1 to 4, although we didn't do qualitative interviews with them, as a part of their reporting process after the post-ketamine sessions or post-CAT sessions, did report a number of kind of QI type qualitative answers to survey questions, which were done in a written form. So although not kind of perfect qualitative methodology, we have a little bit of data there as well. And then hopefully the upcoming studies will seek to clarify that. We've also recently begun to start a 6-month and hopefully a 12-month follow-up for participants who have come through the study in the past and are now kind of out of the therapy for a number of months, hoping to capture changes in terms of what Shannon said, in terms of the scales, but also looking for a kind of qualitative lifestyle and other changes for them as well.
Thank you. Is our addiction problems a major factor in the groups that are coming for assistance and learning? I'm just wondering whether that's a major or a minor issue for the participants, and whether that might, at least you can look at that as an objective measure and see whether or not participation changes the incidence or the ability to manage such issues. And
Pam,
maybe
I
it's
am-
not a problem, which would be great.
Yeah, that's definitely not the case. Pam, I'm happy to be elbowed off the stage if you want to take this one.
I'm happy to comment on this, Anthony. It's a great question, and it's something that we wanted to put into our program and actually study it. As I'm the physician in the program that sees them multiple times, and anecdotally from the patients, we take in their substance use history at the very beginning for
Right.
what alcohol, tobacco, cannabis, and any other substances, whether meth, amphetamines, whether opioid use, et cetera, et cetera. So we record that at the beginning. And then as they go through the program, I bring that into my questioning. How is that going? And very oftenly, what I find very interesting is even prior to their first ketamine assisted therapy session, many of them are already coming down in their use. We're seeing less alcohol use, less tobacco use, less cannabis use. So we're already seeing that in everything that Shannon talked about, you know, the connection and being in the group process or the community of practice process.
Yep.
And then it's for those that it's coming down for, very clearly, many of them quit. There are many of them that have come out the other end and are no longer drinking alcohol and no longer smoking tobacco, et cetera. And we have a non-judgment team. So we know where they're at. And so I think it would if we do get this grant, we'll be able to look at it very clearly. And it is definitely something I've been following, and we definitely see that substance use decreases.
Well, thank you very much. It's very impressive. Thanks.
I have another question. What are some barriers to scaling up this type of therapy? And I guess related to that, I imagine one of them is training. So like, what are the training opportunities for clinicians and therapists, nurses, and are they standardized, accredited? Yeah, thanks.
Yeah, I'll speak to this a little bit and then pass it off again for further elaboration. It is very difficult to scale up a program like this. And in particular, I think it's because a lot of the work we do is successful because it is relational. It's successful because the rapport and trust is really there between the participants and the therapists, also between the participants and other participants. And so you have to manage the team dynamics, the team that is doing this therapy, not even to speak about the practical kind of training aspects. Like, this is really important to cultivate a dynamic of trust even among and between the therapists who are doing the therapy itself. In addition, in terms of kind of practical pieces of training, in Canada and around the world, there are very few training programs for psychedelic practitioners, of which we actually addressed one of the issues there, and Pam and Shannon could speak a bit more to this, but Vancouver Island University has a certificate training program for psychedelic therapists, so they can be doctors, nurses, registered clinical counselors, social workers, who already trained in their field and then coming for subsequent training in psychedelic medicine and how to do this work effectively and safe for patients. And so we've tried to address one of these gaps, but maybe Shannon and Pam, you two can speak a little bit more about the program itself and yeah, more of the nitty gritty.
I'm happy to hop in briefly and then hand it to Shannon to talk about the training stuff. I think before we scale, it needs to be funded. It's not paid for. It's not covered. This is out of pocket. These are patients paying for this out of pocket. And very little of the program is covered by MSP. So just a tiny bit of the doctor's time is covered. And we had a health economist look at our program and crunch our data. And it looks like we save the healthcare system about $30,000 for every participant that goes through our program. And so it's a pretty hard analysis to do. But fortunately, we have BC population data. Nonetheless, it's out of pocket costs. It's not covered, and if we really want to, before we can scale, we need to have it covered. Shannon, do you want to speak a bit more about the training. I'm a little hesitant, I would say too, as a physician, I'm a little hesitant when scaling comes up, because I think this work is so important. I think what the Roots to Thrive team does is so important and is done at such a level of high excellence that the bar is set really high and the outcomes are really good because of it. And so it's not a matter of just putting people through programs, but it's also about training people with really high quality supervision, so that patients get the best therapy and do the best. And hopefully what they do is cease to need programs like this, because their wellness they're back on their foundation and their wellness is there. Shannon?
Yeah, well said, Pam. Thank you. Some of the challenge too, and I feel like we've been at this a little while now, and our plan A is often more like a plan C or D. And it's a lot of this has been, tip of the spear, feeling our way around, what works, what doesn't work, how do we build a team that's solid, that can survive a lot of the uncertainties in this field right now. And I think some of our learnings really come back to this. The Western approach is often one that's like manualized. We manualize, we protocolize, we have kind of a step 1 through 10, and then we see if we can reproduce. And this work, a lot of what is at the crux of why people come to us is, they feel that most of these people would be considered, what is a common term these days is treatment resistant, and often come to us saying, I've been told I'm treatment resistant. And they've lost trust in the system and the many doors that they keep walking through that doesn't seem to work. So there's this sense of like, we have to do this differently. And what does differently look like? It's not a manualized process. It's not pushing people through like an object or, which many of us do, myself included, and are trained to do, for continuity and consistency. It's about like, what would it look like if relationship with these participants, and even elevating them to our level, like where they have as much or more agency in their care as we have in their care. What would that look like in practice? And how do we, hold ourselves to that higher standard, that relational standard, so that we can like learn what security and relationships feel like ourselves, and how we work as a team, and how do we share that feeling, that experience, that sense of worthiness and agency with participants, so that the process it's like a tuning process for another way to engage with a medical system, and to kind of take their power back in a lot of ways. And for us to be able to share that power, which a lot of us aren't necessarily trained to do in our kind of general practice. So long answer to say it's not as simple as scaling, as kind of Pam inferred as well. A lot of this is like re-looking at how we heal as humans, and how we as space holders for that healing engage with them right from the get-go, right from intake to completion. Sometimes I wonder if that kind of how is why our program has been so effective. And yes, we have a manual with steps 1 through 100 as well. But I'm not sure that handing that off and replicating it would be the most significant part.
I just wanted to mention something. So it seems like a lot of the work that you're doing, when you're talking about resiliency, Western ways of knowing versus other ways of knowing, like the Western ways of knowing is really like, deficit based, that you have a problem, and you even use the word treatment resistant. And so like kind of changing the language around that, where it makes it a lot more kind of feeling like you're a part of a community, and then the idea of resilience, like, what are those protective factors that help you get through this, rather than, these are the things that impair you. So do you think that the change in language kind of builds a lot more trust within those communities? And
Uh, yeah, I would just like want to like clap right now for you saying that. Thank you. It's it's so huge. We don't get it because we have been swimming in this for so long. Like how little agency people have in our system right now, and how often they feel like it's their fault and that they are broken beyond redemption, that each door that tells them they are resistant to one more treatment is somehow their fault, their lack, their shortcoming. So to change the language and how we work with people, we don't say treatment resistant. We say, you know, the treatments these days, they're not working for a lot of our population. It's not the population's fault. Our treatments are not fitting anymore. And really working with people is like addictions, depression, PTSD, like they're a natural, normal response to the culture that they are incubating in. It's normal to have these distortions when you're incubating in a distorted society. So there's a lot of like, let's remove the shame that is often paralyzing these people and really work with like a new kind of paradigm for them to stand on. Yeah.
Well, thank you.
Any other questions, or Pam, go ahead.
Oh, I just wanted to add, I think what parallels this is Shannon, do you have the numbers off the top of your head on the first paper we published? You know, the success rates of this program really do speak as well. Do you have those numbers in front of you?
I don't have them memorized. They're quite good. They're in the 70s, 80s. Yeah.
I'll find it here. It is so in the same cohorts, it's our success the rates for that, you know, clinical reductions. So the same sort of clinical reductions you'd see in a clinical trial, or that would be relevant, is 91% saw improvements in generalized anxiety, 79 in depression, 86 86% of those who screened positive for PTSD screened negative at the end of the 12 weeks. And then on the resiliency side, that 92% rated that their life work functionality had improved. So we can put that article in the chat here.
And a lot of these are just, you know, natural outcomes when hope comes in, you know, when people start seeing and feeling positive change, not just at the level of their mind, but they're noticing desire is coming back, and they're noticing they're like starting to be able to hold their emotions, and, you know, without dissociating and going into our typical patterns. And once this starts happening, like hope starts coming in, you know, and then we start seeing symptoms loosen and general perspectives, which are often caught in these measurements, improving.
I guess one final question to wrap it up and look. Oh, never mind. Okay, Tony, go first. Tony.
I just wanted to pick up on this last point, which is really impressive, like to bring that to the fore. And really what you're doing here is, in a very sophisticated way, destigmatizing this whole process. When we talk about stigma in the general context of, you know, societal attitudes, but what you're doing is you're destigmatizing the whole process of providing therapeutic intervention, even if that's a valid term. But I would really encourage you to also not be shy about sharing the success by way of those statistics that were just given by Pam. That's, you know, I can't get over it, but that's the way I think, you know. So when I hear that, it gives me even more confidence in what you're doing, and I'm even more impressed by it. So just a comment.
Thank you.
Thank you very much for sharing this whole thing with us.
Thank you.
Tony, the paper's in the chat if you want to click on it.
Yeah, I saw it there. Thank you very much.
Yeah, Theo, go ahead.
Yeah, thanks for all of this. This has been a really incredible presentation. I would love to hear a little bit more about the groups, the preparatory groups and the integration groups, and specifically I imagine there's a certain amount of training for that component as well for the people who are guiding the group. And I guess my curiosity is about how much that's sort of left up to the individuals and the facilitator to do, whatever emerges from the group, and how much of it is specific to the program.
Ooh, yeah, thank you, Theo. Like, loaded question. There's lots to cover there. One item I didn't cover earlier is so Roots to Thrive is now a nonprofit. It began inside of VIU. And once we realized, okay, this is like, we should keep doing this, it spun off into a nonprofit. And we do provide what we call experiential trainings for people that, there's a couple different forms of training you can go see on the website, but the idea is that people are like immersed in what we're trying to do. Secondly, on the facilitator front, we're also really working with what we really started calling a decolonizing approach. I'm not sure that's possible. I don't say it very often anymore, but really looking at how do we have a more multi-eyed approach where we're not fixing so much on Western medicine, but we're like cracking the door for other ways of knowing that are actually really important in this kind of, having a buy-in of different perspectives. So our not everyone is registered. We generally always have one registered facilitator partnered with either another registered one, or we have some flexibility there. Some of them are somatic energy providers. Some of them are non-registered therapists. Some of them are registered massage therapists or physiotherapists, occupational therapists. I mean, you name it. We've got like a pretty wide team, and we really appreciate the diversity of skills as a collective. The number one piece is, if you're going to come facilitate with us, you need to be able to show up vulnerably. A lot of this is about taking off our professional hats and leading more with in a personal way. It's how we heal in this program, and a lot of our team, we have our own community of practice where we're really working with it so that we're in the same flow as the participants, and so they can trust us as well, that we're also in a place of living in a culture that's really challenging and struggling and resourcing widely. And, as Tony mentioned earlier, like destigmatizing that we all have times when we need to reach out for assistance, and we all have times when we're serving, when we're in times of plenty. So I'm underscoring this because it's a big part, and it's often why our facilitators also stick, because we're like healing right alongside participants. Like that's kind of our decolonizing approach, is really coming alongside. We're also assuming that people need to have like a stability floor there that can only go so far, and training in mental health so that we like know how to kind of manage the complexities. But yeah, otherwise we really try and look at like, what are people bringing in the wider skill set, and can people show up vulnerably to really role model what authenticity looks like when people feel safe.
Yeah, I would like to add to that. A large number of our participants in the program are like pretty high functioning folks that have really had a lot of challenges. We've had a lot of doctors come through our program, a lot of nurses come through our program. Our first cohort was nurses, and mental health workers. We've had police officers, firefighters, paramedics, you name it. They've military veterans families come through our program. And a good portion, in fact, the majority of our program are people who are now on our team, are healthcare providers that actually came through the program themselves. And I think that really speaks to the program, and it really speaks to those of us in healthcare, that there is a lot of depression, anxiety, there's a lot of PTSD, there's a lot of moral injury of people really wanting to show up and do a great job. And, over time, it just gets chipped away at. And then they come through a program like this and they go, wow, healthcare can be like this. I can be this healthy. I can be in a program like this. And we have a few nurses who are on the front lines in ERs and they are now covered to come through the program whenever it's too much, a complete reset. You know, they can sit there and work at St. Paul's Emerge, and then when they need to, they can come through the program and, you know, kind of do like a clean of what they've done. Had to these are highly functional people, and and so I think that really speaks to that we need this just as much. And as Shannon's saying, that the whole team is doing, we are walking alongside the participants as we work on this, and that really goes a long ways. And that is one of the really common exit interview comments, is that it was nice not to feel a hierarchy for once.
Thank you so much. Very enlightening. And I'll just end it with like a big picture question. How does this important work help drive practice and policy, or like what is needed in order to see change and increased access? You obviously mentioned funding. And do you think traditional clinical trial data is needed, or do these kind of cost saving measures and efficacy rates speak for themselves?
Oh, Pam, I know you've got something to say about this too. I'll start. It has been a real personal journey for me in this work. I've been in school or in academia or in big systems for like my entire life. It feels like I'm about as colonized as you can get, and like being involved in this program and really like listening to what works and what doesn't seem to work. And I am reminded, and I'm rigid too, so even though I'm reminded, it takes me a long time to make a shift. It's all comes back to relationships, and not just my relationship with others, but like my relationship with my own body, my ability to like listen in and, you know, be grounded and regulated, and to even know what that means, because I'm actually paying attention to my body and connected to it. And that's like the beginning. And beyond that, there's like this, then it's like, how do I relate to others? And when I go into the clinical trial mode, and Pam and I have both been involved in that whole world as well, it's a really tricky translation process, because in order to have the consistency and the continuity that is required in a trial, right down to the lack of variance in dosing, lack of variance in diagnoses, lack of variance in like all sorts of areas, because that data, the outcomes need to be hinging on certain factors. It is very hard to be patient-centered. It is like really almost impossible to make a decent pivot, even right down to like, is the dosing appropriate for this particular person in their particular condition? And it's been a big struggle for us engaging in trials. In fact, we were like neck deep in one, got one approved, and this fall we backed out. It was just like, we can't do this safely. And yes, maybe biochemically we can do this safely, but when it comes to like what humans need in a treatment program and the kind of flexibility that it's needed to keep them the agents of their own healing process, it then lacks safety. And it is, in our world, it's like it's like really hard to give in either area, which makes trials very difficult to push this work forward in what we would consider a good way.
And I would just add to that it's, you know, these are, many of our patients would not, for the clinical trials that are going forward, they would not make it. They would be excluded. We take in complex patients. It's a complex program, and the outcomes are phenomenal. And so if we could consider in healthcare, why don't we look where the outcomes are? Who's getting really good outcomes? And if we could really move resources to where the outcomes are happening, then I think you would have all the data you need. And if we tried, like just as Shannon said, if we try, the reductionism we would have to do to put this into a clinical trial would not serve the patients. So that's, we decided to err on the side of patients, our participants, and patient partners, as opposed to the clinical trial. So that's challenging because we're in a system that says, show us the evidence, show us the data. And we're hoping that we can say, well, here's the outcomes. And there can be space for that in healthcare too. The outcomes are really good. Can that data be used? Or do we really have to shove it in a pharmaceutical model? Because this is not a single molecule. So I mean, I guess ketamine is, but I mean, the process is not a single molecule. It is not just a hypertensive pill, which, again, we know how problematic that even is for diverse different populations. So, and if we had $10 million in the bank, we'd do everything we could to do it, but that's not where we're at.
And I would also add that as the research team, we've taken a creative approach to kind of a multi-pronged way of kind of trying to advance and push progress forward, right? So it's not just doing these studies and not just reporting on these outcomes, but doing peripheral projects. So for example, like the cost benefit analysis that Pam was mentioning with our data compared to kind of population like pop data, BC data, looking at other ways of advocacy. So, whether that's maybe putting together like a class action lawsuit or maybe having a white paper delivered or lobbying government. I think taking kind of a public pressure approach is also really important in this work, and in part in previous situations has been what has pushed the needle forward, not just the clinical evidence. And I think that, from the Health Canada standpoint, they are quite rigid right now in terms of really emphasizing the need for clinical trials, like really regarding that as gold standard, as it is widely recognized to be in medicine. But I think, as you guys can hear from what Pam and Shannon just shared, this work is different. It's different than the hypertension trial with like 10,000 participants where everyone's randomized. Like, this is very difficult to randomize. It's very difficult to randomize therapy. It's very difficult to have a placebo. What does that even mean? So I think just regarding this work with a bit more complexity is important. But regardless, our team is really trying to push the needle forward in more ways than just the clinical sense.
Yeah, thank you all so much. This was amazing. I've personally been a big fan of your work for a long time, but every time I hear you speak, I learn something new and it opens new, ways of thinking. So I think I speak for the group here. It's been great. So thank you so much.
Very inspiring.
Yeah, very inspiring. And thanks, Vivian, for representing here in person.
Yeah.
Yeah. Thank you so much.
Bye, everyone.
Thank you, everybody.
Thank you.
Thank you.